After we've discharged the patient who's had an MI out of the hospital, we're not done treating them. We want to make sure that this patient doesn't go on to develop another MI down the road. And unfortunately, a lot of patients who do have MIs do have more. So we want to minimize that risk. So after we've discharged the patient from the hospital, usually they're discharged within about a week, we're going to want to make sure that the patient is on a very strict medical and lifestyle regimen. So we want to follow up within 2 weeks after discharge. This is going to be your laundry list of medical management for the patient who has had an MI. Everything bold is going to apply to all patients. So all patients who have had an MI, they will be on aspirin for life, no exceptions. So that increases the survival, it decreases mortality, so we want all patients who've had an MI to be on aspirin for life. They're also going to be on an oral beta blocker for life. Clopidogrel is good for patients for at least 9 to 12 months after they've had an MI. So you can see what we're really giving these patients are multiple different ways that are going to reduce their risk. The beta blocker is going to reduce the oxygen demand of the heart, and the aspirin and clopidogrel are going to reduce the clotting that is normal, but we want that to be less in patients who are at risk for MI. So aspirin, beta blocker, and clopidogrel. We also want, now I say all patients, statins are going to be universally given to MI patients because their risk for developing a future MI and what got them there was the high cholesterol. Even if they don't have a high cholesterol when you draw it in the hospital, they're still going to be on statins because it took a long time of high cholesterol to get them to where they are at now. We don't want them to go on and add to any more of those plaques and put themselves at greater risk. So any patient who has had an MI, after they are discharged from the hospital, they're going to be on statins. So statins increase survival, reduce mortality, so that's going to be another always for patients after they're discharged. Nitrates are good for patients for their pain. And remember, what pain does is it increases the heart rate, and when you increase the heart rate, you increase the oxygen demand, and that can cause further problems. So what we like to give these patients is sublingual nitroglycerin, and that has a tendency to relieve the pain. There is also nitrates known as isosorbide. That's a long-acting nitrate. The reason we don't like to give these to patients, nitroglycerin is better than isosorbide. The reason for that is that isosorbide does have you can develop a tolerance for it. So nitroglycerin is the best nitrates to give. So aspirin, beta blocker, clopidogrel, statins, nitrates for all patients with on discharge for MI. ACE inhibitors or angiotensin receptor blockers are good for patients who, when they're discharged from their MI, their echocardiogram shows less than 40% left ventricular ejection fraction, or any patient that has symptoms of congestive heart failure when you're discharging them. If they're already on an ACE inhibitor or ARB, you don't need to do anything to that dosage. But if they're not on an ACE inhibitor or ARB and they have had an MI and they have a decreased left ventricular fraction, or they have symptoms of congestive heart failure, when you discharge them, you're going to want to start them on an ACE inhibitor or an ARB. Warfarin is going to be good for patients. So these two drugs are not always. These bold ones are always. Warfarin are going to be given to patients who have either symptoms of congestive heart failure or they have developed AFib as an arrhythmia due to their MI. So warfarin is always good for patients with AFib because they can develop a mural thrombus. But we want to keep an eye out for any kind of, while the patient is in the hospital, we want to keep an eye out for any kind of dysrhythmia or that might happen after the MI. So if they do develop atrial fibrillation, then we're going to want to discharge this patient on warfarin. As far as counseling and lifestyle management, we want to definitely make sure that these patients are getting their risk factors reduced. So remember what the risk factors are for MI. Hypertension and diabetes are two of the biggies. So hypertension can be managed with beta blocker. We're going to be giving these patients beta blockers anyway, so that should manage the hypertension itself. We can add an ACE inhibitor to that if we need to, particularly if the patient has diabetes. An ACE inhibitor would be the next thing we would add. We could also use a diuretic. It really doesn't matter. USMLE step 2 and 3 are not going to ask you whether we are going to add an ACE inhibitor or a diuretic. Know that an ACE inhibitor, though, would be preferable if the patient has diabetes mellitus because it is renally protective. So hypertension is going to be the first thing we want to manage. Second, if the patient has diabetes, this patient needs to have strict management of their diabetes because diabetes is a risk factor for MI. So we want to make sure that they're doing strict home blood glucose monitoring, and we want to get their A1C checked every 3 months. Good diet or insulin therapy is useful to keeping that blood glucose down. Cholesterol is managed with statins, and statins should be started in all post-MI patients, regardless of what their cholesterol levels are. If you remember stable angina, we give statins to patients who have an LDL of greater than 100 or greater than 70 if they have diabetes. That's for stable angina. If they've had a heart attack, we're going to give them statins because clearly the problem has developed to such a precarious level that they can't afford, even if they have a good cholesterol number today, it might not be good next week. So we need to have these patients on statins. Of course, smoking cessation is always going to be useful. And then appropriate physical activity. Do we want these patients out running a marathon 2 weeks after their heart attack? Absolutely not. But they should be getting up and moving around. Physical activity is always good. It strengthens the heart. It increases your HDL, and those are all good things. Within 4 to 7 days of discharge, you're going to get these patients stress tested, and this is just going to be your normal stress test protocol that you would do for a patient with stable angina. So you'll do a stress test. Usually these are going to come back positive, but you'll do your stress test either on an exercise stress test, or you can do the echo or the dobutamine echo or the thallium. And if the stress test comes back positive, meaning that on your exercise test, if you get ST depression or hypotension, then you're going to work up for whether we want to give this patient PCI or CABG. And the way we do that is by giving them an angiogram. So a positive stress test, we go to angiogram. If they have blockage in one artery, so disease in one artery, then the treatment of choice is going to be stenting. If it's in if it's in multiple arteries, then you're going to do CABG. And usually these patients are going to wind up needing CABG. But know that, remember that in stable angina, we always do the stress test protocol where we do the stress test. If it comes back positive, we do the angiogram, and then we decide whether we do PCI or CABG. We're going to need to also do this in patients after they've been released from the hospital. So 4 to 7 days after discharge, we want to do a stress test on these patients. As far as advice, what you can tell the patient if they ask you questions, sex is okay after discharge. There's really nothing that says that just having a heart attack itself makes it unsafe to have sex. In fact, a lot of times these patients do develop psychogenic ED because they're afraid of having another heart attack. So because they have that on their mind, it's difficult for some male patients to get an erection. This psychogenic ED I talk about in the psychiatric lectures, but this is diagnosed clinically, and these patients will wake up with erections, but they'll have difficulty maintaining or achieving erection during sexual activity. You can prescribe sildenafil or Viagra to these patients, but they must stop their nitrates if they're going to be on the Viagra, because combining the two of them can cause a precipitous decrease in blood pressure. So this is going to be your useful mnemonic for remembering how we manage post-MI patients in their daily lives. So ABCDE is how you remember it. So the A is going to stand for aspirin and anti-anginals, as well as ACE inhibitors and ARBs. So aspirin and anti-anginals, or nitroglycerin nitrates, those are going to be given to all patients post-MI. And ACE inhibitors and ARBs are going to be given to patients that are discharged and also happen to have either a left ventricular ejection fraction of less than 40%, or they have symptoms of congestive heart failure. Beta blockers are going to be given to all patients, daily beta blocker for every patient post-MI. C stands for clopidogrel, cholesterol management, and cigarette cessation. Those are all good for patients that are post-MI. So clopidogrel, cholesterol management, that's statins, and cigarette cessation. Diabetes and or diet and diabetes management. Of course, if they have diabetes, that needs to be managed as it would anyway. And then healthy diet is very important for patients post-MI. And then exercise and education. So A, B, C, D, E. And the only other thing that's not included here that we talked about is warfarin, anticoagulation therapy for patients that are being released that have atrial fibrillation or congestive heart failure. And that is it.